changes over time, significant memory losses, difficulty with impulse control, as well as things like actually being suicidal. So we know suicide rates are extremely high in patients post-TBI, particularly for those individuals who have repetitive traumatic brain injuries over and over again. So there were a few kind of classic examples of this. There was a boxer who, I actually forget his name, but there was a boxer who was in the news a few years ago who had actually killed his wife, strangled his son, and hanged himself. And they later found out that this was an individual who had multiple injuries. Sorry, it's actually a wrestler, but he had multiple injuries. And he was diagnosed with this chronic traumatic encephalopathy. There was also an NFL player that he was kind of the reason why the NFL looked into the risk of concussions, who also committed suicide at kind of a longer or younger age when he was kind of at his peak, and everyone was wondering, why does this individual who has such a bright future feel this way? And it was, again, that they were diagnosed with this CTE. When they actually post-mortem looked at the brain, they saw that there were significant morphological changes where the brain was almost halved in size of its density due to this traumatic injury over and over again. So it is a quite damaging disorder to undergo. So again, in terms of consequences, we typically break this down into three kind of overlapping consequences of TBI. We have our physical consequences, our cognitive consequences, as well as our psychological consequences. So on this slide, I kind of just have some of the most common things that we see post-TBI in the majority of our population, but this does not in any way encompass all of the symptoms that a patient might experience post-TBI. So in terms of cognition, we might see things like lack of concentration, lack of attention, difficulty with word finding. So oftentimes when it comes to cognitive dysfunction, we see a lot of trouble with communication in particular. In terms of physical changes, we can see loss of gait, imbalances, as well as speech difficulties, lack of coordination. Depending on the part of the brain that's affected, we might see loss of vision or loss of hearing. And in terms of psychological changes, not only do we see kind of acute behavioral disturbances, but as we'll get into, we see a much higher incidence of depression, bipolar disorder, substance use disorder, among others. So when we talk about the etiology, there's a lot of different ways that a patient can get injured. So we can break this down by age. So this is what this slide depicts, is the typical way that patients might result in a TBI. So actually the most common way is through falls injuries. And we do see that there's a distribution regarding age. So the very young and the very elderly, if you see on this slide that kind of red in the middle, I'm sorry if anyone's colorblind, but in the red in the middle, that's going to be your largest section that's associated with falls. However, when we move into kind of the center with our late teens and our early 20s, we see a much higher proportion of those TBIs that are secondary to things like motor vehicle accidents, as well as incidences of assault. So not only is this broken down by age, where we see kind of a different distribution of etiology, we also see that depending on where you're living. So of course, location is going to factor in here. So individuals who live in more rural or suburban areas tend to experience more of the traditional motor vehicle accidents. However, those who do live in more cities with populations greater than 100 people in that city, we see a much higher incidence of things like projectile missile assaults. We also see higher incidence of falls themselves. There tends to be more risk of that, partially because people tend to be walking around a little bit more, so there's a little bit more risk of getting into trouble that way. And then also when we look at gender, just overall, there's a much higher incidence of TBI in males. So we see about 2% higher risk in males. I think that's the first time ever that I've been up here and I said males have a higher risk of something. In this case, this is the situation. TBI is much higher in males than in women. So this slide depicts another way that we can see the etiology. So this is broken down based on force. So there's kind of 5 different ways that we see traumatic brain injury here happening. And remember, this is due to an external force. So any external force that's enough to affect the brain can result in a TBI. So we're not just referring to assaults or bullets, which of course are included here, but even things like cranium distortion at birth, when we actually see forceps changing the cranium. So think about this from any kind of external force. It doesn't have to be an actual assault to the cranium such that it fractures. It could be any kind of blow. So we also see here our kind of punch-drunk blow, so that's a boxing term. It was actually a medical term back in the 1920s that came out in a pretty extraordinary paper that was published in JAMA. And they noticed that a lot of boxers kind of got goofy. That's kind of what they referred to it as. They got goofy years after being in the boxing ring. And one of our kind of earlier neurologists identified, no, this is actually a disorder that's happening to these people. And nowadays it kind of seems like common sense. Yeah, if you're punched over and over and over again in your jaw, it's probably going to have some sort of effect on your brain. But at this time, this was revolutionary to identify that yes, an external force that's hitting your jaw is going to affect your brain. You don't actually have to hit the brain directly to have this external force have an effect. So in terms of review of neuroanatomy, this is your brain. This is the guy that we're talking about. So when we talk about the brain, it's kind of a unique organ system. So our brain is very delicate. So if you ever see any of those like cop shows or forensic shows where they actually show a brain, or one of those like older horror movies where they have a brain and it kind of jiggles around and it looks kind of silly, that's actually pretty accurate. So your brain is really gelatin-like. So it is a delicate being, but that's part of the way that it works. We want it to be delicate because it's transmitting so many electrical impulses that it has to remain that way. However, we also see that it's encapsulated by the skull, which we'll talk about the different layers that protect it. So when we're talking about the brain, it is broken down into those three main components. So we have our cerebrum, which is associated with the majority of our executive functioning at our frontal lobe. So this is kind of our memory and our problem solving. Then we also have our cerebellum located kind of right below our brain, so kind of our mini brain. This is associated with more things like fine point movements and coordination. And finally, we have our brainstem, which is our third piece of our brain. And this connects our brain to our spinal cord, and it's associated with more of our autonomic regulation, so things that are kind of happening without our consciousness. So our breathing, our heart rate, our digestion. And then the cerebrum itself is broken down into multiple lobes. So we have our two hemispheres, our right and our left hemispheres, which we'll talk about how those are broken down further, as well as our four lobes, our frontal lobe, our parietal, our occipital, and our temporal. So remember, you do not need to know this anatomy for the exam, but it is helpful to understand it when we're talking about the way herniations occur. So in terms of protection of the brain, so again, our little jelly brain is wiggling around inside our brain, so we have to keep it set. So the way that we do this is we have our skull, so our cerebrum, and also our meninges. So we have three different layers of dura matter that the primary responsibility of this dura matter is to protect our brain. So it's directly connected to the brain in three layers and then connected to the skull. So when we're looking at our three different layers, we have our outermost layer listed here. So if you look at our outermost, we have our dura matter, we have our arachnoid matter, and we have our pia matter. So those are the three most protective layers. And these tend to be a rather hard membrane associated with protecting our central nervous system. And it's not just seen in the brain, we also see it across the spinal cord as well. And finally, dural folds. So this is important for understanding herniation. So dural folds are actually folds created from that dura matter piece that's protecting the brain. So the two most important ones are listed here. So we have our falx cerebri as well as our tentorium cerebelli. So those have two different functions. They kind of keep the brain where it's supposed to be and protect different parts of the brain from pushing on each other. So if we look at the falx cerebri, it kind of creates a fold down the center of our brain, and it blocks the two hemispheres, our left and our right hemispheres, from pushing into each other too much. It kind of keeps our two hemispheres where they're supposed to be within the skull. We also have our tentorium cerebelli, and based on the name, you probably can guess that it blocks the cerebellum from interfering with our cerebrum. So it kind of keeps the mini brain or our midbrain separate from our cerebrum, which produces our executive functioning. A different way of looking at this is more of our coronal section, so as if we cut off the top of the brain or looking down at what's going on below us. So right at the top of the image, you see our falx cerebri, so it folds in through the top and down the center of the head. And then also in the back here, we see at the end of our cerebellum, and that's where we see our tentorium. So this is the location where we see a lot of our herniation, and when we talk about the Monroe doctrine, it'll make sense why we see herniation so frequently. So in terms of pathophysiology, this can be broken down into our primary and our secondary brain injuries. So primary brain injury refers to the instantaneous injury that's occurring because of that external force. So this can affect multiple areas of the brain. So we see that it can be transmitted to neurons, different nerve synapses, glial cells, as well as our axons. And then the biochemical forces that can result in primary brain injury are typically broken down into contact forces or acceleration or deceleration forces. So contact forces are things like seeing a blunt object blow or penetrating missile injuries, whereas acceleration or deceleration is typically more common in things like motor vehicle accidents, where there's not some external force that's hitting it in terms of someone, swinging a bat and hitting someone in the head. It tends to be us rapidly stopping and seeing that the brain is moving within the skull and hitting the sides of the skull rather than some other object hitting the skull and causing trauma to the brain. We also can break it down based on focal or diffuse. So the majority of our severe brain injuries will be diffuse, meaning that they transmit to different areas of the brain. So we tend to see this also happening in our secondary injury. So one of the most common things that happens with diffuse injuries is actually we see that it can transmit to our axons. So we see axonal or diffuse axonal injury. And secondary brain injury is all the stuff that happens afterwards. So we know that our key pathological trigger here is cerebral ischemia. So cerebral ischemia is this condition in which there's really insufficient cerebral blood flow to meet our metabolic demands. So we're not getting adequate oxygenation of the brain because we have this inadequate blood flow into the brain. So we also see things like intracellular accumulation of our calcium, which can also result in inhibition of our certain enzymes and respiratory, cellular respiratory. And also this can cause amplification of the initial neuronal injury. And when it comes to our secondary injuries, that can happen at really any time after our primary injury. It could be as soon as minutes after, but it might take up to days until we start seeing kind of this diffuse effect after the primary injury. So you do not need to know the schematic. So this is for your information. So do not worry about memorizing this for the exam. But this goes into kind of the nitty-gritty of exactly what happens when we're talking about secondary injury. But the most important thing I want you to understand is that it is secondary to ischemia. All things lead to ischemia, which is that lack of oxygenation to meet the metabolic demands. And our role as pharmacists is to try to reduce that ischemia, which means that we're trying to improve cerebral blood flow without also increasing intracranial pressure. So we'll talk about how we do that. So we really follow the Monroe-Kelly doctrine when we're looking at treating this ischemia. So again, this is probably the most important thing for you to understand in terms of treatment. And it's actually a relatively simple concept. It's the concept that our brain is held within this kind of bony, closed, fixed space. So if there's extra pressure to the brain, it really doesn't have anywhere to go, and that's why we see such significant effects if there is this extra pressure that's added. So when we look at our intracranial volume, it is typically a fixed volume. So it's made up of three major components. So the brain tissue, which typically involves about 90% of the total volume within our cranium. The blood, so that's our cerebral blood flow, which is about 10%. And then our cerebral spinal fluid, which in most situations is going to be a very small amount, less than 3%, but this tends to be where we have a little bit of wiggle room in terms of alleviating pressure. So you might see some non-pharmacologic ways of treating traumatic brain injury, which actually involves draining of the cerebral spinal fluid to kind of make room. But again, you can see it takes up such a small portion of the volume that doesn't really give us too much room to work with. So we also know that our fluid components are really near incompressible. So this goes to the concept of intracranial compliance. So compliance is our ability to change the volume within this bony cage in response to changes in pressure. And again, that pressure comes from those external forces that cause the TBI in the first place. And once we hit a certain once we hit a certain capacity in terms of pressure, we can't change volume enough to adapt to that pressure, and we see that our intracranial pressure rises dramatically. So this dramatic increase in our intracranial pressure is oftentimes where we see the compression of the brain tissue, herniation, as well as cellular death. We also see that this increase in the intracranial pressure is going to interrupt our blood flow significantly. So I also do want you to know this equation. It is a very simple equation, but what components make up our cerebral blood flow? So what is our cerebral blood perfusion rate or our pressure rate? So this is made up of our mean arterial pressure minus our intracranial pressure. So as our intracranial pressure goes up significantly, we see a dramatic decrease in our CPP, which again is our cranial perfusion pressure, which is our ability to actually oxygenate the brain. So if we increase our ICP too much, this causes an imbalance and a dramatic reduction in our CPP. So looking at this kind of as a schematic, so this is kind of showing that bony enclosure where we have our cerebral spinal fluid, our brain, and our blood. So this is kind of the normal breakdown at the top. However, we see that blue mass is showing up. So this is typically what is going on when we have our TBI. So we might have a contusion, a herniation that causes this extra volume to occur within this bony space. So again, typically the area that we have a little bit of wiggle room is first in our cerebral spinal fluid. So our cerebral spinal fluid will go down actually into the spine, so we have less of it in the brain area to try to make room for this mass. But usually the mass itself won't stop growing at that point, it will continue to grow. So then our brain and the surrounding area will have to compensate. So it compensates by decreasing blood flow. And again, this is what results in this hypoxia within the brain that causes all this damage to occur. Like I talked about on the previous slide, this is actually a little bit further down for you guys. I felt like it was a little bit easier to see here right after. But what we see here is the episodes of herniation. So I don't think on the slides I actually have the names, so if you guys want to go forward a little bit to this image, and if you want to write down these are kind of our four most common herniations. Again, you do not need to know this for the exam, this is FYI, but it's good information to have. But as we see this increase in the brain volume that can no longer be compensated by decreasing cerebral spinal fluid or our blood volume, that's when we start seeing the brain actually physically being pushed out of its compartments. So again, in this situation, we're looking at a coronal view of the brain. So as if we cut off the top of the skull, we're looking down on the brain. And you can see here right at the top, we have our falx cerebri. So we start seeing the brain hemispheres shifting, and they're actually colliding with each other. And this is causing more of that hypoxia, more of that injury, that neuronal cell death. And then also at the bottom here, we see where we have our tensordium, which is actually, again, blocking our cerebellum from interfering with our cerebrum. So those two talk to each other as well. Oftentimes we see the cerebrum actually being pushed down into the cerebellum rather than the other way around, but sometimes we do see cerebellar hernias where it actually gets pushed up into the cerebrum. So it's kind of that simple concept of there's just no room to go, so they start knocking into each other, and that's when we see even further cell death and kind of our secondary brain injuries. If you guys don't have it, you can always stop by after. All right, so this is the concept that I talked about with the Monroe-Kelly doctrine, where we do kind of hit that critical volume. So once we hit that critical volume, that's where we see this dramatic spike in our intracranial pressure. Again, considering our equation for for perfusion, we know that as we increase our intracranial pressure, we're going to dramatically decrease perfusion in the cerebrum, which means we're decreasing blood flow and decreasing oxygenation. So this is kind of our autoregulatory curve. So this is generally what we look at in terms of perfusion throughout the brain. So when our autoregulation is intact, so in a normal healthy brain, typically our cerebral blood flow is relatively constant. So we're looking at this red line here. So it's relatively constant as long as we maintain a CPP somewhere between 50 to 150. So as long as our cerebral perfusion pressure is within that 50 to 150 range, we have a nice constant cerebral blood flow and that improvement in oxygenation throughout the brain. However, we see that if it's much lower or much higher, we see significant changes in our ICP, which has significant changes in our cerebral blood flow. So on the next slide, we see what happens when there is a lack of autoregulation. So this is situations that happen during some sort of damage, so TBI. So again, our blue line represents normal physiological autoregulation that occurs, whereby we see that there's normal cerebral blood flow in the situation where our CPP remains intact within that 50 to 150 range. However, when we lose this autoregulation and we see this dramatic increase in our intracranial pressure, we see in this kind of, yellowish orange line, this dramatic drop in our cerebral perfusion. So we see a dramatic drop in our cerebral blood flow. So this should not be happening, but again, this autoregulation kind of gets damaged in the situation of TBI. So again, this all goes back to this idea of we need to maintain things in balance and make sure that we are not engaging in cerebral ischemia. So when a patient presents with TBI, again, the most common way of assessing these patients is using the Glasgow Coma Scale, so our GCS. So this is absolutely the most widely way of assessing a patient for coma. So we typically assess it on 3 different parameters. We look at their eye opening, their motor response, as well as verbal response. And as we'll talk about in the next slide, we don't always evaluate verbal response because there's certainly situations where a patient could be intubated and it's impossible to get that verbal response. But if a patient is able to speak, our maximum score is going to be a 15. And you can see on the slide here, we have different severity scores. So if a patient maintains a Glasgow Coma Scale score between 13 to 15, it's considered to be only minor injury. Whereas if it drops down to 9, or 9 to 12, that's when we see moderate, and any score of 8 or less is considered to be severe. So 3 to 8. So 3 because you get 1 point for everything, even if you're completely non-responsive. So it's impossible to get a 0 on the Glasgow Coma Scale. You also want to consider the effects of altering agents that might be interfering with your examination. So things like ethanol or drug intoxication. So if the patient comes to you and is already intoxicated, of course that's going to have a negative effect on their results, but that doesn't mean that that's due to the TBI. So think about external causes. We also want to think about hypotension, hypoxia, hypothermia, as well as postictal states. So if the patient just had a seizure, a lot of times that can also result in changes in our cognition and our response time. So when we look at our different components, typically we assess eye opening first. So this is scored from 1 to 4, 4 being spontaneous. So this is the normal response, with 1 meaning that we have absolutely no response. 3 would mean that we could have a patient open their eyes secondary to verbal command, but they're probably not opening their eyes on their own. And then also we do include painful stimulus. So we're not, attacking a person with fire or something like that. But when we learned about in our neurophysical exam, it could just be a simple point touch to arouse that patient. In terms of motor response, this is scored out of 6. So 6 being the best, 1 being the worst. 6 would mean that a patient actively follows your commands. 5 would be that they're making localized movements to pain, so if you do touch them with a pointed object, they'll actually move their hand or their foot towards that object to try to identify that pain. 4 would be actually a withdraw from pain, so this means that they sense the pain is there, but the only way they can deal with the pain is by trying to get away from it rather than identifying that, oh, I can probably just stop this pain by addressing it. We also see that when